to another insightful episode of MedSynapse podcast series. I'm your host, Hetvi Shah, and today we are bringing you a crucial discussion in the recognition of World Rare Disease Day. Rare disorders often pose unique challenges, not just in diagnosis and treatment, but also in long term patient care. And joining us today is an esteemed expert in this field, Dr. Mohammed Nidhal, a renowned neuro-anesthesiologist with extensive experience in managing complex neurological cases requiring palliative care. Dr. Nidhal, it is a pleasure to have you back here. Welcome to the show again.
Thank you. Pleasure is mine.
So, Doctor, to set the stage for our discussion, could you provide an overview of what palliative care means in the context of rare disorders, and how does it differ from traditional palliative care approaches?
Yeah, but definitely. The rare disorders, they are conditions, which affect a very small population in the world. So, we don't have a clear-cut guidelines for the Indian population, but, the WHO as well as the US as well as European guidelines have set something like, 1 in 10,000 to 1 in 50,000 and so on. And we got a multitude of rare disorders. You can take it as neurological, metabolic, hematological, musculoskeletal, and so on and so forth. And when we are going to talk about, palliative care when it comes to these rare disorders, how it differentiates between, the traditional palliation, which we usually see in cancer patients or neurological patients and in rare disorders is that, the diagnosis of the rare disorders itself comes a bit late. That is, we try to find out other causes which can be treated whenever a patient presents with a very, bad condition or, a diagnosis which seems a bit rare. In that case, we'll try to, find a diagnosis which can be easily treated, and the diagnosis comes a bit late, and the palliative care result starts a bit late for such patients. As I told in the last webinar itself, palliative care should be started as early as possible. But the challenge here is it starts a bit late. And besides that, there are no protocols when it comes to rare disorders. Like when we see in cancer patients, we got a lot of cancer patients, so we've seen lots of studies and we've set protocols. But when it comes to rare disorders, there are very few studies, and each condition is so unique, and the palliative care and the treatment per se is so individualized. I feel these two things are difference between traditional as well as palliative care when it comes to rare disorders. Just one more point that when you're going to talk about palliative care, the children are also. When you're going to talk about rare disorders, mostly it is the children who are affected because there are lots of genetic as well as inborn errors of metabolism, and dealing with such patients is a unique challenge in itself.
I think that's a very important distinction, and I really like the way you emphasize on children also, because those are also the generation which gets rare disorders. So yes, we should make that also important. So doctor, with that in mind only, how early should palliative care be integrated into the management of rare disorders, and are there specific markers or stages where intervention becomes very critical?
What we do is usually palliative care starts usually at the time of diagnosis. Be it any condition, be it any diagnosis, maybe a cancer, maybe a neurological disease where the progress is going to be in a declining phase itself. So palliative care should be started as early as possible, usually at the time of the diagnosis itself. As I already mentioned, all these rare disorders, usually they are progressive, and they have, over time the patient deteriorates. And as you had asked, there are some crucial steps where we can, integrate this palliative care, or, where we intervene at a very crucial stage. Usually it is at the time of diagnosis, number one. Second, it could be whenever, when you're going to manage the symptoms, when the symptoms start to worsen, where, it could be as simple as something as pain, mobility issues, feeding issues, and so on and so forth. The functional decline, the patient is not able to, maintain themselves on their own. They require some help. They require their family's help or a caretaker's help. These things, you know, you can introduce new treatment of palliative care inside this. Also, when the patient's requiring frequent hospitalizations, the patient can have feeding issues causing lung infections that can cause something. The patient is, not able to urinate properly. They're having a catheter inside them and it's causing, an infection and the patient is requiring hospitalization and so on and so forth. So, usually at these stages, you can implement the palliative care more aggressively for these patients. So usually it's at the time of the diagnosis and when the patient is developing, symptom related to that disease, when there is, a decline in their functional status, and when the patient is requiring, more and more hospitalizations. These are the crucial steps where, we know that the patient is slowly, worsening or there is a decline in their clinical condition, and we can try to bring in more comfort care or, the palliative care or end of life care to be, if we can discuss in that context also, we need to bring in all those forms of treatment or palliative care, comfort care, whatever we call it.
I think that makes a lot of sense also, and I think early intervention could actually help in improving the quality of life as well, right?
Yes, exactly.
So now, Doctor, rare disorders often present with complex, multisystematic symptoms as well. So managing pain, fatigue, and distressing symptoms can be quite challenging, I'm sure. So how can healthcare providers effectively address these issues?
Usually these rare disorders, especially inborn errors of metabolism, even neurological conditions, all these diseases, they affect multiple organs, usually. So it's either the lung, liver, kidney, heart, all these systems are involved. And the symptoms vary from disease to disease and as well as symptom to symptom. Patient with lung infection, they'll have breathing difficulties. Maybe with heart, they'll have some other symptoms, swelling. They'll be very tired all the time. With neurological disease, they'll be having mobility issues, so on and so forth. So usually we need to have a multidisciplinary team, including physicians who are trained in managing these patients, physiotherapists, dietitians, psychologists, as well as palliative care specialists. The common symptoms, if you can, encompasses, you'll have a pain management, you'll have mobility issues, you'll have fatigue issues, they'll have difficulty, maintaining the nutritional status, as well as, they'll have these cognitive behavioral complex issues and all. So when you're going to have pain issues, it can be, neuropathic pain or a musculoskeletal pain, which you have to manage with appropriate medicines. It could be as simple as, paracetamol, an acetaminophen or an NSAID, or it can go up to, opioids, higher up the scale. Fatigue is also very common in such patients when, we need to give them adequate nutrition, teach them how to conserve their energy and such kind of treatment. Cognitive behavioral therapy, the patient, their neurological, their cognition is low, the sensorium is low, they're slowly losing their memory, especially, in neurological diseases like chorea, Huntington's chorea, some forms of leukomalacia and all those. In those conditions, you'll have to, incorporate this cognitive behavioral therapy as early as possible. Some patients, they'll have respiratory diseases, respiratory insufficiency. They won't be able to breathe well. You might have to, include this long-term oxygen therapy or BiPAP support. Some patients, they won't be able to eat. You'll have to give them artificial nutrition, clinically assisted nutrition hydration. You might have to give them rice to feeding, or you might have to put a gastrostomy. Such kind of treatment is available. For mobility, you will have assistive devices. You have your crutches and your wheelchairs. You might have to incorporate that as early as possible, when they're losing their mobility, so that they don't fall and they don't injure themselves and, end up in fractures and so that. And a very important, key thing what we have to keep in mind is we have to regularly assess these patients and try to incorporate as much as care we can give before the next symptom begins. Whenever we feel that the patient is prone for aspiration. He's not able to swallow properly. Introduction of a tracheostomy before the lung is involved is a good option. Or, whenever we feel that the patient is becoming more and more fatigued because of, nutritional insufficiency. Before we get to that stage of fatigue, we can insert a Ryle's tube, or we can put a gastrostomy so that the nutrition is maintained in that patient. And even for an example, if we feel that the patient is, not able to walk well, we can introduce the wheelchair or the crutches so that the patient is able to mobilize themselves comfortably and safely, so that they don't fall off and they fracture their bones, which can again, increase their morbid status, and it will lead to a complex medical condition again. So, as physicians, palliative care physicians, and as a part of the multidisciplinary team, we should regularly assess these patients so that we can incorporate any comfort care or palliative care or any form of treatment before the patient develops the next symptom or the next worsening phase.
Yeah, I think a multidisciplinary approach is something that is really important in these rare diseases also.
Yes.
And also, I think a comprehensive, tailored approach also to symptom management is truly essential, I feel.
I won't say a comprehensive treatment. As I told earlier itself, it should be tailored. Each disease.
The tailored treatment, yes.
Yeah.
Now, doctor, another difficult yet crucial aspect of palliative care is breaking sensitive news to patients and their families. So, what are your recommendations for healthcare professionals when discussing prognosis and treatment limitations?
So, breaking bad news itself is an art. We cannot say it. I can say like how you can break your bad news, but it comes with experience, as well as it is more about observing how the patient attenders or the patient responds to it, and we got to respond appropriately. It's an art. If you're going to see the literature, there are lots of breaking bad news concepts and all. It requires empathy, clarity, patient-centered approach. All those stuff is there. The usual protocol is the spikes protocol, which you can easily follow to break a bad news. The setting, spikes is the mnemonic. The setting where you can choose a private room. You got your P for perception, where you can understand what the patient is, what the patient already knows or the patient family already knows. The invitation, ask how much detail they want to, hear, and how much they want to discuss. If they want it in bits and pieces or everything at a go, it makes sense whenever the patient, is going to live for a longer time. The patient's going to not die, or the patient's not going to worsen for the next 10 years. Then the patient can say, okay, I want to know what comes in the next 3 or 5 years. Then I'll after the 5 years, let me know what will come later on. So that the patient is not as anxious, as they want to be. And you got your K for knowledge. You have to deliver the knowledge about the disease and what they can expect very clearly, without any medical terminologies, as simple as possible. And then you got to acknowledge and validate their feelings. That is E for emotions. And you got the S for strategy. Then we got to strategize the plan. As I had already mentioned, it's always, tailored according to the disease and according to the patient, how much they know, how much they want to know, how much, what is their response to the, the strategy you're giving, or the knowledge, the information you're giving. It all depends on all that. Some keywords, what I could say is, you can give all these things with a bit of empathy. No need to break it down just like that. You can, give it in bits and pieces, some digestible information, digestible parts. And you should always be open to questions. You should not cut down the patient and say that, okay, listen to what I'm saying. You should always be receptive to what they're saying. And then you can clarify the questions. We should always keep in mind that it's a very difficult situation for them, knowing that themselves or their loved one is slowly drifting away. They are not going to live, for a very long time, or they're going to be in a very bad condition very soon. It's a very difficult situation for them. So we got to, listen to them and then respond appropriately. To be honest, it's an art. And next thing is you have to follow up on these discussions as frequently as possible. If at all you're going to break the bad news, you're not able to deliver the full news, what they're going to expect and, how they're going to respond to it. You got to, follow up on the discussion so that the patient knows how much ever, they can deliver how much ever information of the disease or about the prognosis or this treatment as much as to the patient. These things are kind of important when they're going to talk about delivering the bad news.
Yeah, I think clarity in communication plays a major role, and as you also mentioned, it comes with experience also. So that is really important, and it actually makes a difference also to families how the news is broken to them.
Yes.
Now, Dr. Caregivers play an indispensable role, but often experience high levels of stress and burnouts as well. So, what support systems or resources should healthcare professionals recommend to them?
Yeah, it's a very important topic actually, caregiver support. Caregiving in rare diseases is emotionally, physically, and very importantly, financially exhausting, because the patient is going to be in a very bad state, in some conditions for a very long period of time. It could be, decades together, to be honest. Yeah, and the common issues when it comes to caregiver support is lack of respite. Respite is, emotion. A caregiver timeout. Whenever a patient is being taken care of by a caregiver, you give the caregiver, a break, a small break, so that they can emotionally vent out. They can have their own time. They'll be able to, do something else besides, taking care of the patient per se. And also the emotional strain which comes along with which comes along with taking care of the loved one. And very importantly is the financial burden on the family also. What I could say is, support systems could usually include, educating the patient as well as the patient caregivers, and training them like what they can expect and how to cope up with, the burdens. Especially the emotional burden and, how to, go about with the lack of with the respite care and all that. And we can also provide respite care, like in our setup, we usually have a 2-3 day, workshop where they can come, they can, take the time off, they come, the patient is also admitted with us, someone else takes care of the patient. And the patient attenders, they are a bit relaxed for the 2-3 days, that's more than enough for them actually. And they get good sleep because, the patient's attenders, the caregivers
support, yeah.
Yeah, when they come with us, they are very burnt out. It's like you're seeing a patient with anxiety. They don't have sleep. They're very jittery. They got this big dark circles. They are binge eating. They are not able to sleep at night because of that. They are constantly watching TV and all that sorts. It's very sad to look at them at that stage. So we give this respite care in our centers also. And also these counseling and support groups, whenever we find, forming the support groups, they are able to discuss what all issues they're going on amongst themselves, how they're managing, so that, they always believe that, a patient who's being, they listen to other caregivers who are suffering the same thing instead of a doctor. So it also helps, it's very beneficial for them also. Like they've already gone through, so they're giving their, the experience on that. And we are just like a third person, we are giving just theoretical knowledge. So that also helps to some patients. And, we got this financial assistance programs also by the government of India, by multiple NGOs, which, support them. They give free treatment for these patients. They give free nutritional support, whatever it's possible. And also, you can also, use this legal and future planning, whenever the patient is, going at the end stage, you can involve this legal, the legal support, how they want, it could be medically as well as, how they want their finances and how their properties and all that stuff can be involved as early as, whenever they are going to, lose their cognitive ability, we can involve that, prior to that itself. An important point, what I could say is, you should pick up caregiver distress, caregiver burnout very early, so that the patient, the caregiver does not lose the interest to take care of the patient. That is very important. A lot of patients, they go into this burnout and they feel like, okay, let them die or let them go elsewhere. I'm not able to take this anymore. We've seen patients like that. They come and dump the patient in a center and they go off. That's not a very good, approach, because the patient is a patient and they need to be taken care of by their family. They want to be with their family, but because of all these things, it's a very complex interplay. So we should keep in mind that we don't let the patient caregiver go into a burnout, and we should assess them also so that we can manage that burnout and distress accordingly.
So I think caregivers also need support, and then providing them right resources also can prevent burnouts in them, because it is very essential and they play a pivotal part also, I think.
Yes.
Now, Doctor, before we conclude, what message would you like to share with healthcare professionals, caregivers, and patients regarding the importance of holistic palliative care?
Number one, what I would like to say is palliative care is not end-of-life care. There is so much more to palliative care than end-of-life care. The usual mentality among, at least the doctors I know, is that they feel palliative care should only be introduced when the patient is going to die. Okay, let them die peacefully, let them die comfortably. That is when they involve, palliative care treatment options. But that is not palliative care. Palliative care goes much beyond end-of-life care. That is at the time of diagnosis itself. When you're going to diagnose the patient with, an incurable or a progressively declining disease, or the patient is going to lose themselves, you got to introduce palliative care then itself. The other thing is that, palliative care can somehow help patients maintain their functions so that maintain their symptoms, manage the symptoms when you're going to introduce palliative care early, You can give them appropriate pain medicines, you can give them appropriate mobility devices, you can give them appropriate information on how to, maintain their nutrition, hydration and all that. And also, I would say to the fellow healthcare professionals to involve the multidisciplinary team for the treatment of such patients. The physiotherapist, the dietitians, the concerned specialist in that field, as well as palliative care physicians, so that you'll get a well-rounded knowledge on how to, go about with the patient. And also for the caregivers, what I would like to emphasize is that you should seek support, whenever you feel that you're not able to manage the patient. And it's very difficult to manage the patient all alone. So definitely seeking support is not a bad thing. There are lots of NGOs, lot of centers, to help such patients, to give, to manage such complex diseases also. And prioritizing self-care is also a very important thing. You should not think that letting this patient go there for 2-3 days and I'm enjoying myself, it's not a bad thing. It is a good thing. So that you can come back refreshed and take care of them maybe, for some more time. And, if at all you're not doing that, you will feel burned out more and you will just leave the patient and go off.
Yeah.
That is a bad thing.
True.
And also for, if at all there are any patients listening to this, all patients or everyone deserves to have a dignified life, and everyone is supposed to be, treated compassionately. And so it goes with patients with rare disorders, or anyone who is in a phase of, they are declining progressively, or, they are having any prolonged illness, which is going to ultimately lead them to be bedbound or something like that. So all patients, even if they are going to be bedbound, or if they're going to be at their end of, at the phase of their end of life, they should be managed dignifiedly, they should be managed compassionately, and all patients should have their individual care. And, the ultimate goal is to, instead of treating the disease, you should treat the patient. You should be caring for the patient instead of, going behind the treatment per se. Treating the disease per se. You should also manage the patient in a holistic manner. So that's what I would like to say, and I would like to conclude with that.
Yeah, I think that's such a powerful message to leave our audience with. And Dr. Nidhal, thank you so much for sharing your expertise on this critical topic on this special day. So thank you so much, and it's been an enlightening discussion today.
Thank you very much. Thank you very much.
And to our listeners, thank you for tuning into this special episode of the World Rare Disease Day on MedSynapse podcast series. And remember, if you're a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate to join us on the MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, stay informed and stay compassionate. Take care.